This lecture will provide an overview of the digestive system as well as the process of digestion and absorption. In 1822, a fur trapper accidentally shot a 19-year-old man named Alexa St. Martin. An army surgeon by the name of Dr. Beaumont was able to successfully patch him up, but unfortunately, St. Martin was left with a hole in his stomach called a fistula. Dr. Beaumont took advantage of this situation and over the next 10 years performed 238 experiments on St. Martin. This enabled him to learn a lot about the process of digestion. The digestive system, or the alimentary canal, begins at the mouth and ends at the rectum and is responsible for the digestion, absorption, and metabolism of the food that we ingest. Now, the alimentary canal or digestive tract or gastrointestinal tract, any of those that you would like to call it, is approximately 9 meters or 29 feet in length, and the main organs are the mouth, the pharynx, the esophagus, the stomach, the small intestine, large intestine, rectum, and anal canal. So this is, if you think about the main organs, it's all of the organs that food passes through on its journey of digestion. And then the accessory organs include the teeth and tongue, the salivary glands, liver, gallbladder, pancreas, and appendix. We're going to talk about each of these in detail. So when we eat something and food is taken into the digestive tract, that is referred to as ingestion. And as the food travels through the digestive system and is broken down into simpler nutrients, this is the process of digestion. And the way that it does this is the digestive system has a process for moving this food product through the digestive system, which allows it to be broken down, and then once it's in small enough particles, then it can be absorbed into the digestive system, and what is not absorbed gets eliminated. Here are some fun images I thought I would throw in. It's always a bit different when we look at the drawings or images in the textbook, and then we're in surgery and we're actually seeing what the real thing looks like. So top left, what do you think that is? If you said a really bumpy liver, then you would be absolutely right. That is not a normal looking liver. It looks very sclerotic to me. However, it is a liver. The top left, or top right rather, what do you think that is? If you guessed pancreas, you would be absolutely right. That is a pancreas. On the left bottom, this long wormy thing is the appendix. And then the bottom right picture is showing the gallbladder. It's in picture B. You can see kind of that purplish, weirdish thing there that lives underneath the liver is the gallbladder. Here's another image during a laparoscopy of some sort, and it just reiterates how we have to train our eye for surgery to be able to identify what is what in there. And, you know, if there weren't these labels there, it would kind of be difficult to discern what organs are what, where something starts, where something ends, because it's covered with a lot of fat. And, you know, once you kind of start dissecting things, then it gets bloody. It's kind of difficult to tell, but the more experience we have, the more we train our eye, the better we will be able to identify what structures are, and then most importantly, anticipate what our surgeon needs. There are 4 primary layers to the wall of the digestive tract, and the innermost one is the mucosal layer. The outermost one is the serosal layer. So in between there, if we're Going from the inside out, we have the mucosa, which is the membrane that lines the GI tract. It produces mucus. It has those goblet cells in there, helps to lubricate and protect the GI tract. Then moving towards the exterior, we have the submucosa, which is the layer of connective tissue that contains the vasculature, the lymphatic vessels, and the nerves. The muscularis is the muscular layer, and this is composed of smooth muscle, and there are circular muscles as well as longitudinal muscles, and those muscles contract in two different ways. There's kind of this snaking type contraction that's called peristalsis that helps to move contents along the digestive tract, along the intestinal tract. And then the other type is called segmental, and that kind of helps to mix and churn the contents as it moves along to help with mechanical digestion. So there's the muscular layer. And then the most outer layer is called the serosa. We might also refer to this as the visceral peritoneum, right? Anything inside the abdominal cavity is covered with visceral peritoneum, and then there's the parietal peritoneum that actually lines the abdominal cavity or makes up the most inner layer of the abdominal wall. Okay, so it's also important to note that, contents of the digestive tract aren't just kind of all tossed into the abdomen, free to move about the country as they want to. There's this thick fold of peritoneum that is called mesentery, and the mesentery helps to anchor the digestive tract to the posterior wall of the abdominal cavity so that it kind of stays in place. So the mouth is where digestion begins. It's also referred to as the oral cavity. It's a hollow chamber. It has a roof, a floor, and side walls. The tongue is also in there. It is lined with mucosa like the rest of the digestive tract. The roof of the mouth, or the palate, is composed of two different sections. The hard palate, which is the front part. If you're to use your tongue and kind of feel up near your teeth, you would feel the hard palate. And then posteriorly in the cavity is the soft palate. Now the uvula is attached to the soft palate, and its job is to prevent food and liquid from entering the nasal cavities. If you've ever taken a drink of something and started to laugh or cough and it went out your nose, that is not a fun feeling, especially if it's something like Coke or Dr. Pepper that has bubbles. So, we can live without the uvula, and sometimes we do resections of the uvula. Sometimes it helps with sleep apnea. The floor of the oral cavity is made up of the lingual frenulum, and this is, if you were to look in the mirror and lift up your tongue, you see a little piece of tissue that connects your tongue to the floor of the mouth. That's the lingual frenulum. And the papilla are the taste buds, right, or the elevations on the tongue, and the taste buds are located on the papillae. So we have that going on in there. We also have a bunch of teeth. We have incisors, or our front teeth are used for cutting and ripping and tearing food. We have our canine teeth, our molars, which are made up of bicuspids and tricuspids. And some of these teeth we refer to as baby teeth, which means they fall out, right? And then we get new ones that grow in. The teeth that do fall out are referred to as deciduous teeth, and if you know that trees that lose their leaves are called deciduous, that might help you remember that deciduous teeth are baby teeth. And then we get a full, beautiful, pearly white set of 32 permanent teeth, typically. All right. Something else interesting to note is that there is also some tooth anatomy. And when we talk about the tooth, the bone-like material of the tooth is referred to as dentin, and this is covered with enamel. And the root, or the part that is up inside the gum that we can't see, is covered by something called cementum. All right. And there's also a very thin membrane that lines each tooth socket and helps to anchor it to the bone. And this is called the periodontal membrane. Here's a look at that oral cavity. You can see the uvula here. Actually, this is a very small uvula hanging down at the back of the soft palate. We got the hard palate here. We have the soft palate, of course, is posteriorly. We get a picture of these tonsils here, the palatine tonsils, and the tongue. So I think I went a little overboard on that last slide, but here are the words that go with what I was talking about on the last slide about the teeth, right? So deciduous teeth, we have about 20 baby teeth. We have a full set of 32 teeth, and typically that set is complete between the ages of 17 and 24. Here's a look at that tooth anatomy. You can see the crown is the part of the tooth that extends past the gums, the neck there as it kind of comes in, and that's where the gum line typically lives, and then the root is hidden beneath the gum line, and you can see the dentin there, and then the inside meaty part of the tooth called the pulp, that's where the vasculature and the nerves live. There are 3 pairs of salivary glands, with the parotid gland being the largest of the salivary glands. We secrete about 1 liter of saliva per day. Because they are located outside of the GI tract, or they're not a part of that direct pathway, right, that food makes its way through as it's being digested and absorbed and excreted. So it is referred to as, they're referred to as accessory organs. The parotid glands open, the ducts of the parotid glands open into the mouth opposite the second molars. If you have mumps, this is what becomes inflamed, okay? The submandibular glands, as it suggests, are low in the mouth, on the floor of the mouth, and the ducts of those open up on either side of the lingual frenulum. And then the sublingual glands, again, are on the floor of the mouth. And the salivary glands contain enzymes. An example of one of those enzymes is amylase, and this begins the breakdown of food, okay? And these enzymes work similar to the enzymes that are in detergents that we wash our clothes with, or if you've ever had a stain and you put Shout on the stain on your clothes, that is a similar process where it starts to break down those complex proteins or carbohydrates or whatever, and aids with digestion. Here is a look at our friends, the salivary glands. You can see the parotid gland, this most gigantic gland here, and you can see that it opens up, comes down through here into the mouth. And then we have the submandibular glands located here, down low in the mandible, literally, and then the sublingual glands under the tongue, both opening up into the floor of the mouth. There are various disorders of the mouth, including infections, cancers, congenital defects, and other disorders that can cause serious complications, including malnutrition. Some infections and cancers of the mouth may spread to other parts of the body. An example of cancer of the mouth is leukoplakia, and I have a picture of that coming up on the next slide, which is common in smokers or those that chew, and it is a precancerous condition of the mouth tissue. Then we have snuff dipper's pouch, which is typically caused by chewing tobacco. And lastly, squamous cell carcinoma, which is the most common form of mouth cancer. Here we can see the snuff dipper's pouch between the cheek and gum there. Leukoplakia typically develops between cheek and gum as well. Here you can see that it is on the upper gum between the lip and gum there, and then an example of mouth cancer down here. Cancers can also develop on the lips with extreme exposure to sun, but there are lots of lip balms that they make that have sunscreen in them, so it's always a good thing to wear that if you're going out. Tooth decay is another situation that can occur with the teeth. So we call that dental caries. And it's a tooth disease typically due to bacteria or infection of the teeth. And can also lead to gingivitis. Gingivitis typically, in most cases, results from poor dental hygiene. So brush your teeth and floss. Dental hygiene is very important to keeping you healthy. Periodontal disease is an inflammation of the periodontal membrane. Remember, I said there's a membrane that anchors the tooth into the bone of the jaw. And interestingly, individuals with periodontitis are 2 to 3 times more likely to have a heart attack or a stroke or other serious diseases. At the top here, you can see a picture of some cavities or dental caries. And then in some cases, the individual may choose to have these dental implants. And so that's what you see on this bottom right image here. So what they would go ahead and do is remove the affected teeth, and then they're going to go ahead and put an implant into the bone. And sometimes they can do this all at once, but sometimes it's a multi-step procedure where you have to wait for the implants to heal in the bone and then bring the individual back to put the actual teeth in to the implants. Thrush is a result of a yeast-like fungus called Candida. And you can see in this image here, this white kind of cheesy colored patches on the tongue and in the mouth. This is how it presents itself. It likes to attach to the warm moistness of the inside of the mouth. Sometimes you will see this in little babies, particularly because their immune system isn't completely developed yet. However, in adults, it's most commonly seen in individuals with suppressed immune systems, like those with HIV/AIDS, or they're on antibiotic therapy for some reason, like if they've received an organ transplant or something like that, where they're having immunosuppressive therapy of some kind. Cleft lip and cleft palate are congenital defects that can also impair the mouth. Cleft lip is, the medical term for that is chyloschisis, and cleft palate is palatoschisis, and we are left with this a split in the lip or split in the hard and or soft palate. Typically, we like to fix this when they're really little, and sometimes it becomes a more serious situation if we have a baby that has cleft lip, cleft palate, and they can't breastfeed or latch on to a bottle, then we are also at risk of them developing malnutrition. So we like to get this fixed as soon as possible within the first year if we can, earlier if there is worry of malnutrition because the baby cannot eat. When we talked about the respiratory system, we talked about the pharynx as well. And so here we're revisiting it when we talk about the digestive system. Remember, we said that it does serve as a pathway for both air and food. So here we're talking about its job when there is food involved. And the same areas of the brain regulate the pharynx as do respiration. So the medulla and the pons regulate the involuntary swallowing mechanism, and then areas of the cerebrum are going to regulate the voluntary motor control of swallowing, right? We can swallow on command. And so in some part it is voluntary, but it's a muscular tube, right? And there's three parts. We said the nasopharynx, the oropharynx, and the laryngopharynx. And then we get to the esophagus after that. But the pharynx is the throat. The part behind the nose is the nasopharynx. The part directly posterior to the oral cavity is the oropharynx, and the portion directly posterior to the larynx is referred to as the laryngopharynx. Next, we come to the esophagus. The esophagus is distal to the pharynx, and it is also lined with a mucous membrane. It is a muscular tube about 10 inches long, and it connects distally to the stomach. So proximal to the esophagus is the pharynx, distal to the esophagus is the stomach. There are sphincters at each end that help to keep the material in the esophagus, right? So there's the upper esophageal sphincter and the lower esophageal sphincter, often referred to as the cardiac sphincter because it's kind of near the level of the heart. And its job is to transport food material, right, into the stomach. So what can go wrong with the esophagus? Well, gastroesophageal reflux disease is one condition that we see, and this is what gives us heartburn, right? So what's happening is that sphincter is not working correctly, and it is allowing acid to come back up into the esophagus from the stomach, and that's what causes that burning sensation. Frequent episodes can trigger asthma attacks, severe chest pain, bleeding, narrowing, and chronic irritation of the esophagus. Chronic symptoms can also lead to precancerous lesions in the esophagus. This is referred to as Barrett esophagus, and can eventually lead to cancer, where there has to be some sort of resection of the esophagus. All right. Another common symptom is hiatal hernia, and hiatal hernia is when the stomach herniates up through the diaphragm. So the esophagus passes down through the diaphragm. There's a natural opening there, and sometimes the fundus, the top little part of the stomach, will work its way up through that opening of the diaphragm, and then we have something called a hiatal hernia. And here we are looking at the hiatal hernia. You can see in the top of this image a normal, happy stomach, and then on the image to the right of that, you can see where a portion of the stomach has herniated up through that natural opening in the diaphragm. So we can fix this with an open procedure or a laparoscopic procedure. It's called a Nissen fundoplication, and if they can, they like to do it laparoscopically. It's less invasive for the patient, quicker recovery times, but what they're going to do is they're going to grab onto that stomach and they're going to pull it back down into the abdominal cavity where it belongs, and they're going to take a part of the stomach and wrap it around the esophagus right up against the diaphragm. So hopefully that's going to keep it from herniating back up into the thoracic cavity. Well, they can also put some mesh to reinforce that portion of the diaphragm and hopefully dissuade the stomach from reherniating up through that opening where the esophagus passes through the diaphragm. Us humans, we only have one stomach, but cattle, deers, and giraffes have 4 stomachs to deal with. That's partially because they have to try to digest a bunch of cellulose material called hay or grasses, which are impossible for us to digest because they are so cellulose rich. So they have 4 stomachs where, you know, the hay kind of hangs out and it helps it to break down a little bit more. Interestingly, seahorses and platypuses don't have a stomach. Their food goes straight from their esophagus into their intestines. So let's talk about the stomach. The stomach is responsible for mechanical digestion. So food and nutrients from food does not get absorbed in the stomach. Okay, it's a pouch where the food stuff or the chyme goes into the stomach and it gets churned around, all right, and it gets mixed with some juices. And a couple interesting things about the stomach. One, it secretes hydrochloric acid, and the hydrochloric acid is what helps to what assists in the mechanical digestion, and it secretes about 2 liters of that a day. However, if it didn't have those amazing goblet cells producing mucus to protect it, the stomach would literally dissolve itself. Now, the inner machinations of the stomach, if you will, is lined with these little folds called rugae. And if you've ever had your stomach growl, when mine does it, it's at the most inappropriate times. However, it is those folds rubbing against each other because the stomach is empty, all right? So that's what causes the stomach growling that you hear. So at the top part of the stomach, we have the cardiac sphincter, right? The esophagus attaches to that. And we're going to look at a picture of it next. We're going to see the fundus of the stomach, which that part that kind of raises up, and then the body, and then from there into the pylorus. And the pylorus is like a little S at the most distal end of the stomach, and that is the beginning of the small intestine. And there's a sphincter there as well. And that sphincter regulates the flow of chyme out of the stomach and into the small intestine on its journey. Here we are getting a look at the stomach. So up here, like I said, this is where the esophagus attaches to the stomach, and there's a sphincter there. And then this big part that kind of rises up above is called the fundus. The rest is called the body until we get down here to the pylorus, where we get this little turn in the stomach, and then the duodenum, right? And so this begins the start of the small intestine. Like I said, you can see this kind of rough ridges of the rugae inside the stomach. You can also see that it's a very muscular organ as well, because it's got to kind of squish and churn and help to mechanically break down whatever food we have just put into it, right? So what can go wrong with the stomach? Well, The pylorus can actually have abnormal spasms, and that is common in infants. Also, pyloric stenosis, which is the narrowing of the pylorus, which inhibits food from flowing out of the stomach. So this could cause an obstruction, and we can fix that surgically. Stomach ulcers is another condition that can develop. It's typically caused by bacteria, right? We used to think that most ulcers were caused by acid, but a lot of times we find ulcers are caused by an overabundance of Helicobacter pylori, all right? And this is bacteria that typically lives in the stomach. However, sometimes it can run amok, and when it does, that is when we see a higher incidence of ulcers. NSAIDs, or non-steroidal anti-inflammatory drugs, can also increase the chance of ulcers. And because we know that it is more commonly caused by bacteria, we can treat that with some antibiotic cocktails to help our patient out. Sometimes an increase in H. pylori can be associated with excessive consumption of alcohol or eating foods that are highly processed, or also the use of tobacco products. If there is some sort of cancer that develops in the stomach, a lot of times this is identified late in the game. And, some symptoms that typically present are heartburn and nausea and vomiting, and it's kind of just treated with over-the-counter stuff for a long time by the individual. But surgical removal is the best treatment for stomach cancers. Here we can see the lovely stomach. This top one that you're looking at on the left is a healthy stomach, and then if we look right below that, you can see a stomach with a bunch of ulcers there. And then the top right, we see this very narrowed pylorus. So X marks the spot of the stomach. Food wants to get out, but this is into the duodenum here. But it's very narrowed through here, and that can cause an obstruction. Food can't get through, so we can open that up. And then here you can see like these white lesions here and this tumor that is forming inside the stomach. This whole entire thing right here, the tumor. The small intestine is about 20 feet long. It's really long, and the reason that it is really long is this is where chemical digestion takes place. Remember, the stomach is responsible for mechanical digestion predominantly. The small intestine is where the nutrients are going to be absorbed, and the inside mucosal layer of the intestine is covered with these little doodads called villi, and these villi help to increase the surface area and help with the absorption of those nutrients. There are three sections to the small intestine: the duodenum, which comes off the stomach, the jejunum, and the ileum. And if you want a fun way to remember this, you can remember DJ Ileum. It plays some great toots. Okay, so the small intestine. So now, with technology as it is, endoscopes really help us to determine if something is going on in the GI tract, right? So the first endoscope was developed by a German physician in the 1800s, and it wasn't a flexible one like we have now. We do have rigid scopes that we can use as well, but typically flexible ones are used for the digestive tract. We can kind of get around corners and, see what's going on in the intestine or the stomach or the colon. In 1868 was the first time we ever got a look inside of a stomach of a live person. However, again, this was still with a rigid endoscope. Now we have those flexible endoscopes that are a lot easier for us to use and definitely a lot easier on the patient. Here is a look at the beautiful small intestine. You can see this fatty tissue that is hooked to the small intestine. The lymph nodes live here, and the vasculature, you can see that very well, the vasculature here. And what they're doing here is probably running the bowel. And running the bowel means you're just going to kind of go along the entire length of it, feeling it, looking at it, making sure that it's okay. When we have a patient that maybe has free air in their belly, that means they have a hole in their digestive tract somewhere. It could be a hole in the stomach from like an ulcer. It could be a hole in the intestine, small intestine, or colon from a perforated diverticuli or something like that. However, they're going to run the bowel when they get in there. They're going to be looking to see if they can find where the defect is or if the rest of the length of the bowel looks okay. All right, so the small intestine. So what can go wrong with the small intestine? The small intestine can develop something called enteritis, which is intestinal inflammation. Inflammation in the duodenum can produce feelings of nausea that can lead to vomiting. And this is typically due to some sort of infectious particle. Gastroenteritis as well could be some sort of bacteria that is causing inflammation of the stomach and the intestines. We also have something called malabsorption syndrome. And malabsorption syndrome leads to a lack of absorption of nutrients, right? This can lead to anorexia, signs of weight loss, abdominal cramping, bloating, anemia, and fatigue. Usually, malabsorption syndrome is caused by surgery. So if we've operated on the bowel, that can put the bowel in a state of shock. Also, blood flow changes and disease. If we have situations like maldigestion, this could be because of a deficit of digestive enzymes or bile that helps to break down food so that it can be absorbed. Also, we have to think about the normal bacteria in the digestive tract. If there isn't a normal flora in the digestive tract, then this can also result in maldigestion as well. Something interesting that can occur in the small intestine is called a Meckle's diverticulum. And this Meckle's diverticulum is an abnormal pouch of tissue that occurs on the small intestine. It's actually a remnant of the umbilical cord, if you can believe that. And oftentimes it's necessary for us to do a resection and remove that diverticulum because stuff can get trapped in there. You can see this Meckle's in this image here. It's very black, so it can necrose and food bits can get trapped in there, and eventually it can erode through the wall and cause a rupture of the intestine. And then we have contents of the intestine spilling out into the abdomen, which is bad news. So far, we've predominantly discussed the main organs of the digestive tract, including the mouth, the pharynx, the esophagus, the stomach, and the small intestine. So now we're going to take a little detour over to the liver and the gallbladder and the pancreas. These are all accessory organs of the digestive system. The liver is the largest gland and organ in our body. It fills up the right section of the abdominal cavity and extends over to the left side. It's right underneath our ribs on the right side. It is classified as an exocrine gland because it manufactures and secretes an enzyme called bile. So the liver has many jobs, but one of its jobs in this context is to manufacture bile. And this bile is going to get stored in a little holding pouch called the gallbladder. So if you look at these real images on the far right, that top image is the gallbladder that you see laying on top of the liver. Now, the gallbladder typically lives underneath the liver, kind of stashed away, and they've actually pulled it up and it's laying on top of the liver. That's not its normal home, if you will. So the liver secretes bile, the gallbladder stores it, and the liver has a variety of metabolic functions, and we'll talk about some of those, but mostly we're going to talk about that when we talk about chapter 19 and nutrition. So the liver has a variety of ducts. Now the hepatic duct, we're going to look at an image here in a second, but the hepatic duct's job is to drain bile from the liver. The cystic duct is the duct by which bile enters and leaves the gallbladder, and the common bile duct is the union of the hepatic and cystic duct. So we're going to look at that. The gallbladder, like I said, lives underneath the liver, and its job is to store bile that is produced by its friend, the liver. Here's that image that I promised we would look at, so let's get our bearings. Up here, this purple line is Mr. Liver, and living underneath Mr. Liver is Mr. Gallbladder. Again, remember, liver is producing the bile. Bile is going to leave the liver. It needs a storage place. So it's going to travel down the hepatic duct, all right? And it is going to take a detour to this common bile duct. It's going to be stored in the gallbladder, all right? And some of the bile can continue down this common bile duct, and it gets dumped out into the duodenum. This is the duodenum right here of the stomach. They've cut it away so that we can see the pancreas and all that fun stuff. So the some of the bile is going to just be take this pathway and be excreted into the duodenum, and the exocrine properties of the pancreas. The pancreas makes these pancreatic juices, and they're going to be secreted into the stomach as well. All of these enzymes are going to help to facilitate that breakdown of food so that it can be absorbed for nutrients so that our body can use it. So what happens when we take out the gallbladder? When we take out the gallbladder, one thing we want to make sure we do not do is clamp the common bile duct, because once we take out the gallbladder, whatever bile that's made from Mr. Liver is just going to flow into the common bile duct and drip into the duodenum. So this is why sometimes individuals say after they have their gallbladder out that they can't eat starchy foods or they can't eat pizza or something like that. The bile helps to emulsify and break down fats. So that could be why that their body has a difficult time breaking that down, because there's not going to be a reserve of bile. It's not going to, eat some pizza and then the stomach says, hey, I need you to send down some extra bile so that I can break down all this fat from the pepperoni that this person just ate. That's not going to be able to happen. So there isn't going to be a reserve of that. So that can cause an issue. But this gives you a good idea of the common hepatic duct, or this is called the biliary tree. So common hepatic duct coming down from the liver, common bile duct or the cystic duct coming from the gallbladder, and then those two join to form the common bile duct. The gallbladder can develop stones. The stones, we refer to those as calculi. That's the medical term for stones. And those stones are made of bile and some calcium salts. And we call this cholelithiasis. Cholelithiasis is the condition of having gallstones. Cholecystitis is the inflammation of the gallbladder that can and will accompany cholelithiasis. And these stones can obstruct bile canals, or that biliary tree that we saw, can lead to jaundice, can also lead to pancreatitis. How do we know if there's stones stuck there? Well, oftentimes intraoperatively, we will perform something called a cholangiogram, and the cholangiogram allows us to inject dye intraoperatively into the biliary tree, take some x-rays, and see if there's any stones in there. And if there's any stones blocking that biliary tree, way back when, we used to do something called a common bile duct exploration, which was not a fun time. However, now they can send patients afterwards to get an ERCP, which uses ultrasonic waves to actually break down those stones. So that is pretty cool. Hepatitis means inflammation of the liver, and it is often characterized by jaundice, liver enlargement, anorexia, changes in the color of stool, and darkened urine. And remember, the liver is also responsible for removing that yellowish brown pigment from the hemoglobin in broken down red blood cells. So the liver also helps to filter that out as well, and other various toxins. So some things that can cause liver inflammation are various toxins, bacteria, and viruses, like hepatitis A, B, and C, or there are some parasites out there as well. Hepatitis A and hepatitis B, we're pretty good at curing those, but hepatitis C, we're not so good at curing hepatitis C yet. There are other different types of hepatitis that they have also identified as well. All of this can lead to cirrhosis of the liver, which is a degeneration of the liver tissue involving the replacement of the normal healthy liver tissue with fibrous fatty tissue. So you can see what a cirrhotic liver looks like in the image there. This can lead to cancer over time, and can also cause something called portal hypertension. And portal hypertension is due to the cirrhotic liver blocking the flow of blood through the liver. So remember, we talked about the hepatic portal system. This resistance that is now being created in the liver is causing a backup in the hepatic portal circulation. This can result in a backup up the line in the various digestive organs like the stomach, and if these and the esophagus, as well as other digestive organs. And if this happens, these veins become widened, similar to varicose veins that we talked about. If we're standing for a lot of time and blood is pooling in the veins, it can cause these varicosities. Similar things can happen here, and if those varicosities rupture after erosion by stomach acid, then vomiting of blood is going to occur, and this massive amount of bleeding can result in death. Here is a picture of a cirrhotic liver. And then this kind of gives you an image of these varices that are developing because of this damage to the liver. It's more difficult for blood to flow through there, and so you get these varices, these little bead-like bulges in the veins, and if those rupture, then that can cause the bleeding. I have to mention that in this image, the pancreas kind of looks like an ear of corn. That's kind of weird. Anyways, this is the pancreas. Remember, the pancreas is both an endocrine and exocrine gland. Endocrine because it secretes insulin, remember? And exocrine because it secretes those pancreatic juices into the duodenum that help us to break down our food. All right, so cannot live without the pancreas. Something happens to the pancreas and we can't do a resection, then that is not a good outcome. However, there are some instances where tumors of the pancreas can be resected in a very involved procedure called a Whipple procedure, where part of the stomach and the intestine and the gallbladder and the pancreas is taken out, and they kind of put all these things back together again. So we need our pancreas. It helps us break down food, and it also helps control our blood glucose levels. So what can happen to our dear pancreas? Like I said, I already mentioned cancer can be a very serious situation and fatal in a majority of cases. Pancreatitis, which is inflammation of the pancreas, can be caused by the ducts of the pancreas being blocked. And so this causes a backflow of those juices, and they literally start to digest the pancreas, which is bad. Cystic fibrosis, we already talked about how the mechanisms of cystic fibrosis, those chloride ion pumps are not working correctly, right? So chloride is going to be pumped out of the cell membrane, out of the cell through the cell membrane. Sodium is going to follow, and water is going to follow that. So we're left with this very thick, sticky, mucus-like substance, and that is going to also inhibit the flow of those pancreatic juices. Here we are back at one of the main organs of the digestive system, the large intestine, or you might hear it called the colon. And the small intestine joins up with the colon at the ileocecal valve, and that is on the right side of our abdomen. And we'll look at a picture of that in a second. The large intestine is about 1.5 meters long, and it forms the lower or terminal portion of the digestive tract. It is primarily responsible for absorbing the fluid that is left in the food product that has traveled through the digestive system, been broken down. The majority of the nutrients have been absorbed in the small intestine, and now it's time for the fluid absorption. So this is where that happens, in the small intestine. The divisions of the small intestine are the cecum, the ascending, transverse, descending, and sigmoid colon, the rectum, and the anus. All right, so here's that image of the large intestine that I promised. And right here, I'm going to circle in red. This is the ileocecal valve. This is where the small intestine hooks in to the large intestine on the right side of our body. I always remember that because there's like this blind pouch right here called the cecum, and Mr. Appendix is hanging out right there. The appendix is on the right side attached to that cecum. Okay, so this portion of the intestine is called the ascending intestine because it is moving food stuff upwards, up the right side of the body. And on the right side here, this is a special part we need to talk about. This is called the hepatic flexure. That gets its name because it's right there by the liver. So there is a ligament here at the hepatic flexure that attaches the large intestine to the abdominal wall so that it doesn't go anywhere. And then as we move across, we have the transverse colon, and the transverse colon is the only part of the colon that has these real predominant pouches called haustra. And again, we have another flexure. Anybody know what this one's called? If you said splenic flexure, you would be right. The spleen is over there on the left, and that's how it gets its name. Again, there is another ligament that goes from the splenic flexure of the colon to attach it to the abdominal wall. And now we are on descent. So this is called the descending colon, right? And it's on the left side of our body. Food stuff is moving down. Fluid has pretty much been absorbed, and we are on our way out the door. So this little S-shaped part right here is called the sigmoid colon, and then this last little portion, the rectum, and then the opening to the outside world is called the anus. So what can go wrong with the large intestine? Well, if there is a change in the normal motility or the rate at which the food stuff moves through the large intestine, then we can have issues. If the product is moving too fast, then we are going to get diarrhea because there is not enough time for the large intestine to do its job and absorb the fluid like it should. The opposite can occur when there's decreased motility, there's decreased movement of the feces through the large intestine, then we get constipation. And if there has not been a bowel movement for more than 5 days, then we start getting a little bit concerned. What else can happen? Diverticulitis. Diverticuli are these little pouches or openings that are on the inside of the intestinal wall, and food can get stuck here. So individuals that have diverticulitis, they suggest that they don't eat popcorn or certain seeds or nuts because they have a tendency to get stuck in these little pouches, and over time they can erode the wall of the large intestine and eventually lead to a perforation. A couple other complications of the large intestine are colitis and colorectal cancer. Colitis is just a generic term for an inflammatory condition of the large intestine. If it's present for long periods of time, it can become a significant risk factor for colorectal cancer. Some symptoms might include diarrhea, abdominal cramping, and constipation. Some forms can also lead to bleeding and intestinal ulcers. You might have also heard it referred to as irritable bowel syndrome. It can also result from autoimmune diseases such as ulcerative colitis, and then another type of autoimmune colitis is called Crohn's disease. If you had to choose between the two, irritable bowel syndrome is better to have because it doesn't typically reoccur in another part of the intestine. With Crohn's disease, we can remove the affected portion of the large intestine, and there is a chance that it will reoccur again in another part of the intestine. If we have to remove a portion of the intestine because of colitis or Crohn's disease or colorectal cancer, whatever the case may be, If we remove too much of the colon, we might not be able to hook it back together again. And in that case, the patient is going to have something called a colostomy. And a colostomy is where we bring the large intestine out through an opening in the abdominal wall, and we attach a little bag there that's going to catch the waste. We can also do this with the small intestine. Sometimes, even if we can hook the bowel back up properly, the doctor might decide to let the patient's bowels rest, quote unquote. And so at this point, the patient might get a temporary colostomy or ileostomy or jejunostomy. And then at some point, we could return to surgery, take that ostomy down, and go ahead and reconnect things as they should be. The appendix is probably more trouble than it's worth. It's really not good for anything, and it typically causes trouble. About 7 to 12% of the population have appendicitis before the age of 30. Technically named the vermiform appendix, it is this blind-ended little tube that's attached to the cecum near the ileocecal valve, and like I said, has really no important function. Maybe 100 years from now, we will be born without one. Who knows? But appendicitis is the inflammation of our dear old appendix, and if it is left untreated, it can rupture, and then all of the contents from the appendix go into the abdomen, which is really bad. We don't want that to happen. So that does require surgery. Appendicitis, it usually presents with tenderness in the right lower quadrant, and there can be some rebound pain that's maybe a little bit higher up, but typically lower right quadrant is where we're going to have that tenderness. It can be removed by a small little open incision, but lots of times we do it laparoscopically. That's a lot less invasive for the patient. If we are going to do an open appendix removal, we use an incision called a McBurney's incision. We've mentioned the peritoneum before, and remember, there's two types of peritoneum. There's the parietal peritoneum, which makes up the innermost layer of the abdominal wall, and there's the visceral peritoneum that lines all of the abdominal cavities, all right? Or the abdominal organs, excuse me. And behind that peritoneum, the parietal peritoneum that lines the entire abdominal cavity is called the retroperitoneum, or the retroperitoneal space. So behind the peritoneum, there's the retroperitoneal space. Some interesting things live there. If we dig down far enough, we will get to the spine. Also, a part of the aorta lives back there, part of the ureters live back there, the kidneys live back there as well, of course. So there are some extensions to the peritoneum. One we already talked about, the mesentery. The mesentery is an extension of the parietal peritoneum, and it attaches to most of the small intestine, and it has the lymphatics, the vasculature, and the nerves that innervate the small bowel. There's also the greater omentum, and we kind of refer to this as a fatty curtain, and this curtain hangs down from the lower edge of the stomach and the transverse large intestine, and it serves as kind of this blanket over the intestines. So here on the left side, you see the mesentery. It's the same image that I showed you previously in this lecture. And then on the right side, the omentum. This is fat. And again, it has vasculature, lymph nodes, lymphatic vessels, and nerves. The individual in this top image is not pregnant. That is actually due to ascites. Ascites is an abnormal accumulation of fluid in the peritoneal space. This is typically due to complications caused by cirrhosis, congestive heart failure, kidney disease, peritonitis, cancer, and or malnutrition. And then we also have a condition called peritonitis. Peritonitis is the inflammation of the peritoneum. This is typically a result of some sort of invading microorganism or other irritating condition that may be going on in the abdomen, say the appendix ruptured, or something of that sort. Some other abdominopelvic organ has a rupture. Remember, inside the intestine is a bunch of different bacteria. One, which we talked about, E. coli, produces vitamin K, and those are necessary for proper digestion. However, if those bacteria get out of their normal home and they invade the peritoneal space, that can lead to peritonitis. So we're coming into the home stretch here. We're going to talk a little bit about digestion. As we said before, there's two different types of digestion. Both are needed for us to get the nutrients to our cells that they need. The first one is mechanical digestion. This starts in the oral cavity. Our teeth help out, right? Those salivary glands are producing enzymes to help start the breakdown of food, and the swallowing, the peristalsis, the churning in the stomach, all mixing with digestive juices and moving them along the digestive tract via peristalsis and segmentation. That is all the mechanical digestive process. Now, the chemical digestion is the process of breaking up those larger molecules, proteins, fats, carbohydrates into smaller compounds and molecules. Then they can be properly digested by the small intestine. So we're going to finish up this lecture by talking about enzymes and chemical digestion in a little more detail. So remember, enzymes are basically chains of amino acids that have been folded into functional proteins, and they act as something called catalysts. And catalysts are enzymes that speed up specific chemical reactions. So without them, things would happen a lot more slowly. So all of these digestive enzymes break down these bigger, more complex molecules like proteins, fats, and carbohydrates by hydrolysis. Remember way back when we talked about hydrolysis, and that's basically using water to split apart molecules into smaller molecules. So any of these enzymes, you'll know them because the end of the name has ASE attached to it, like lipase, amylase, maltase, sucrase, lactase. All of those are enzymes that help to break down our food. So, like we said, complex molecules like carbohydrates, proteins, and fats. Carbohydrates start to break down by amylase, which is an enzyme that is in our saliva. However, typically we eat our food so quickly that this digestive enzyme doesn't have much time to do its work. So when the chyme gets to the small intestine, then the pancreas secretes pancreatic amylase, and this helps to further break down those complex carbohydrates, and the end result is monosaccharides, which are one molecule sugars, if you remember that, the most simple type of sugar. Protein digestion starts in the stomach with hydrochloric acid, and the enzyme pepsin is what's going to break down those peptide bonds, right, that are in the complex proteins. And at the end, what we end up with is these very simple amino acids from the digestion of protein. And lastly, lipid digestion really doesn't happen until we get to the stomach and the small intestine. By the time fats get into the small intestine, they're trapped in these tiny little droplets, and more pancreatic juices called lipase help to split them apart into their components, and the end product of fat digestion then is fatty acids and glycerols. So the last step, the last part of the story really is absorption. And absorption, like we said, predominantly occurs in the small intestine. That's why the small intestine is very long, right? And it has all of these microvilli that help the body to absorb those fatty acids, glycerols, monosaccharides, and amino acids that the body has worked so hard to break down. That's why the surface area of the small intestine is so critical, because this is where predominantly all the absorption of nutrients takes place in our body. All right, everyone, that concludes our lecture on the digestive system. I hope you found it helpful. I hope I helped to demystify some of the more complex components of this system. And once again, thank you for listening to my lecture.